Okay, let's unpack this. Welcome to the deep dive. Today we are taking on a topic that is, well, it's absolutely fundamental to your practice, it's non-negotiable for patient safety, and most importantly for you right now, it's a guaranteed high-yield cornerstone of your upcoming Gujarat University MD anesthesiology exams. We're talking about pre-anesthetic assessment, or PK.
That's the mission. And we're not just treating this as, some theoretical exercise. We're approaching this as if you're preparing for a demanding viva or that crucial theory paper.
The one where this topic can be that huge 20-mark long answer question.
Exactly that one. Our goal here is to give you the structure, the clinical reasoning, and all the nuance you'll need to really excel.
So let's start at the very beginning. For the examiner, for that first line of your answer, what is the authoritative definition of pre-anesthetic assessment?
It's the clinical roadmap. But the formal definition you need is this. Preoperative evaluation is the clinical foundation that guides all perioperative patient management.
And it's required before any anesthetic.
Before any anesthetic, absolutely. Doesn't matter how simple or complex. It's the official start of the whole perioperative journey, from diagnosis right through to recovery.
Okay, so that's the foundation. What are we building on it? If an examiner asks for the goals or objectives of PAC, what's the list we need to provide?
You need a structured list. A 4-point list that shows you understand the modern scope of our work.
Okay, number one.
First, we have to rigorously determine if the patient can safely tolerate the physiological stress, not just the surgery, but the specific anesthetic we plan to use.
Makes sense. Number two.
Second is to mitigate perioperative risks. This means you're proactively looking for the big predictors of problems, things like pulmonary or cardiovascular complications, and figuring out how to manage them.
Right, and number three.
Third is about the technical side of things. We're looking for potential problems that could complicate the anesthetic itself.
The classic difficult airway.
The difficult airway is the prime example, but also things like, limited IV access or maybe managing a complex device like a pacemaker or an AICD.
And the fourth objective. This feels like the one that has expanded the most recently.
It has. Number 4 is optimization. We have to ensure all the patient's pre-existing medical conditions are managed as well as they possibly can be. This can involve structured programs like prehabilitation or getting a patient into a smoking cessation program.
So we're moving from just checking a box to actively trying to improve the patient's condition before they even get to the operating room.
Exactly. And that leads directly to the importance of all this in patient safety. We have hard data on this.
Oh, this is good for the exam.
Yes. The Australian Incident Monitoring Study database, for instance. It showed that inadequate preoperative evaluation was a contributing factor in 3% of all perioperative adverse events.
3% is not a small number when you think about the volume of surgery.
It's significant.
Yeah.
And it proves that a proper evaluation isn't just bureaucracy. It directly reduces morbidity and enhances patient outcomes because we're maximizing their health status before the stress of surgery begins.
Okay, so let's frame this specifically for the exam hall. We've called this high yield. How exactly do the examiners at Gujarat University tend to test this topic?
Oh, it's guaranteed to appear, no question. Most commonly, it's that big 20-mark long answer where you need a really comprehensive, systematic structure.
Covering everything from history to planning.
Everything. But they also love to pull out specific parts for short notes. You might get describe a PAC clinic, or discuss the ASA classification and its limitations, or preoperative management of ACE inhibitors.
And then a Viva.
In the Viva, it'll be a direct fundamental question. What are the goals of a pre-anesthetic checkup? Or take me through your difficult airway assessment. If you can't answer these basic PAC questions, you're signaling you're not ready for independent practice. It's that simple.
All right, so before we dive into the nitty-gritty of the history and the examination, let's set up the framework, the when and the how we approach the patient. This itself can be a short note. Let's start with the timing.
The timing really shows how our specialty has evolved. It's moved towards anticipatory care. Historically, the assessment was often rushed, maybe the night before or even just before surgery.
Which we've all seen happen.
We have. But the modern standard, the best practice, is to do the assessment several days or even weeks before the surgery.
And this is where the dedicated pre-admission clinic, the PEP clinic, comes in.
Precisely. That clinic formalizes the process.
So why is that time interval so valuable? What does it buy us clinically?
Time is the single most valuable resource we have. It lets you identify complex problems early, like a new heart murmur that needs investigation.
So you're not discovering it on the morning of surgery.
God, no. It gives you the window to order those non-urgent but necessary tests and echo pulmonary function tests. And critically, it gives you enough time for proper optimization. You can't get a patient with poorly controlled diabetes or severe asthma ready the night before. It's impossible.
And what about logistics? Coordinating with other hospital services?
A huge benefit. It allows us to alert the transfusion service for cross-matched blood, talk to the pacing team about a pacemaker, or book a critical care bed in advance for a high-risk patient. This planning dramatically cuts down on same-day cancellations. It's just more efficient.
We also have to talk about the regulatory side of this, the documentation requirements. This is a detail you can't afford to miss in a theory paper.
You cannot miss this. The recognized standard is that the full history and physical examination must be documented within 30 days before the procedure.
But there's a crucial second part to that rule.
There is. The critical detail is the need for reassessment. You have to formally reassess the patient and document their current status within the 48-hour period immediately preceding the surgery.
Why is that so important?
It ensures you catch any acute changes. A patient who was fine a week ago might have developed a cough, a respiratory infection, or new chest pain. You have to capture that.
So beyond just talking to the patient, where else are we gathering our information?
We have to be medical detectives. Of course, the history and physical are the cornerstones. But you must review all the related diagnostic tests, any interventions, and you should be speaking to their treating physicians, their cardiologist, their endocrinologist.
And previous anesthetic records?
Honestly, the single most important document you could find. It's a goldmine. It can give you clues about a difficult airway, adverse drug reactions, or an unexpected need for ICU care last time. It's invaluable.
So this all speaks to the expanded role of the anesthesiologist. We're not just in the OR anymore.
That's a critical mindset shift for an MD student. You are the perioperative medical specialist. The role starts with screening and triage. Then you lead the optimization, coordinating with surgeons, cardiologists, nephrologists. You're the central point for perioperative planning.
And we're also setting the standards.
Yes. An important exam point is that we are often the ones required to develop the consensus standards for when surgery should be canceled or delayed for medical reasons. That shows clinical leadership.
Okay, let's wrap this section up with the administrative essentials: documentation and consent.
The preoperative note has to be complete, systematic. It has to clearly state the anesthetic plan, regional, general, sedation, and then there's informed consent.
Which is a legal and ethical requirement.
A mandate. You have a duty to discuss the proposed plan, the alternatives, their pros and cons, and the relative risks. Documenting this conversation is essential, and it also really helps reduce patient anxiety.
And a key distinction for the exam.
Be careful to distinguish the responsibilities. The discussion about the risks and benefits of the surgery itself, that is always the surgeon's job. Our focus is the anesthetic.
Right. Now for the part that forms the bulk of that 20-mark answer, history taking. This is the bedrock of everything we do. We need to be systematic.
Absolutely. We start with the present illness. This gives us the context. First, you need a crystal clear understanding of the diagnosis and the surgical procedure. Why are they here? What's being done?
Then we need to know the story of the illness.
Exactly, the duration and severity. What's the clinical course been like?
Yeah.
Any recent exacerbations? Is the disease stable, or is it getting worse fast?
And finally, the urgency.
The distinction between emergency versus elective surgery is critical. An emergency procedure is, by itself, a major unmodifiable risk factor for bad outcomes.
Because you have no time to optimize.
You have no time. This immediately tells you that you need to be more vigilant and probably need to plan for more intensive postoperative care.
Okay, now for the past medical history, here we're really focusing on severity, stability, and that key concept, functional reserve. Let's start with the heart, cardiovascular disease.
This has to be thorough. You're hunting for any signs of ischemic heart disease, congestive heart failure, or symptomatic arrhythmias.
What are the specific symptoms you're asking about?
Obvious ones like chest pain and palpitations.
Right.
But also severe dyspnea, or, and this is a huge one, extreme fatigue with simple exertion.
That's the red flag for a lack of reserve.
It's a massive red flag. If a patient gets exhausted climbing one flight of stairs, their compensatory reserve is shot. You also need to define the severity, maybe using NYHA class, check for stability, and document all their prior treatments, stents, bypass surgery, medications.
How does this concept of reserve apply specifically to our elderly patients?
That's a vital point. In an elderly patient, things like coronary disease, a long smoking history, and diabetes can eat up almost all of their cardiac reserve. They're living right on the edge.
So even a small insult during surgery can push them over.
Exactly. A little bit of blood loss, a brief drop in blood pressure, and they can decompensate systemically very quickly. You must document any history of MI, angina, CHF, or significant valve disease.
Okay, moving to the lungs. Respiratory disease.
Same principle.
Yeah.
Severity and stability. You're asking about dyspnea, orthopnea, wheezing, any changes in their sputum.
And for patients with known COPD or asthma.
You have to get more specific. What are their triggers? When was their last exacerbation and how bad was it? What are their current medications, inhalers, steroids? Are they on home oxygen?
And a quick point on assessing their functional status.
Yes, it can be tricky in the elderly. Often their respiratory function is limited, but their ability to exercise is limited by, say, arthritis. So they can't exert themselves enough to get breathless, which can mask the severity of their lung disease.
Right. Diabetes. A dual focus here, I believe. Control and complications.
You've got it. You need objective evidence of control, not just, I feel fine. Ask about their recent HbA1c, their typical blood glucose readings. And for the exam, you must talk about complications.
So we're actively looking for them.
You're ruling them out. Peripheral vascular disease, renal failure, and especially neurological disorders like autonomic neuropathy, which can make their blood pressure incredibly unstable under anesthesia.
And a quick note on gestational diabetes.
With GDM, control is paramount, aiming for that 80-120 range. The specific point to mention is that oral hypoglycemic agents cross the placenta, so these patients are often switched to insulin beforehand to prevent fetal hypoglycemia.
Moving on to renal disease, or CKD, the big issue here is often pharmacology, right?
It's a huge issue. CKD can be silent in the early stages, so you have to ask.
Yeah.
Ask about urine output, and for those on dialysis, you need the details.
When was their last session? What's their dry weight?
All of that, and any problems with their access, like infection or thrombosis. But the key implication for us is drugs. Low molecular weight heparins, like enoxaparin, are cleared by the kidneys. In a CKD patient, their action is prolonged, which means a much higher risk of bleeding.
Same goes for some of the newer anticoagulants.
Absolutely. The DOACs, especially dabigatran, have to be dosed very carefully based on their creatinine clearance.
Okay, neurological disorders. What are the key things to ask about here?
A history of stroke, or TIAs, is mandatory. You need to know the timing, the presentation, and if possible, the cause. Was it carotid stenosis, or was it cardioembolic from something like atrial fibrillation?
And seizure disorders.
Document the type of seizures, their frequency, and confirm they are compliant with their anticonvulsant therapy. If you can get plasma levels, even better. And always remember, any pre-existing cognitive disorder is a major risk factor for post-operative delirium.
A quick mention of hepatic and endocrine systems.
For hepatic disease, ask about chronic infections or known metastatic disease. If you suspect either, you need to see recent LFTs and a coagulation profile. For endocrine, the big two are thyroid problems. Is it well controlled? And adrenal issues. Specifically asking if the patient is on long-term steroids.
Which has huge implications for perioperative stress response.
Huge. And finally, just be aware of associated syndromes. Down syndrome, for example. You should immediately think possible congenital heart defects, thyroid issues, and always anticipate a difficult airway due to the large tongue and potential atlantoaxial instability.
Let's turn to the patient's own history with anesthesia. This can be more predictive than any lab test.
Oh, absolutely. This section is pure gold. You want a detailed account of any previous anesthesia exposure.
What kind of detail?
What type of anesthetic did they have? General, regional. Was securing the airway easy or difficult? Any problems with IV access? Did they need an unexpected ICU admission? And even note their weight at the time, because a big weight change can alter the airway anatomy.
You mentioned difficult airway. What's the #1 predictor?
A history of previous difficulty with intubation. It's the most predictive factor we have. You have to actively ask for the clues.
What might a patient say that would tip you off?
They might say they had a really bad sore throat afterwards, or that a tooth was chipped. Or they might say something like, the doctor told me I needed a small tube, or they said I had a funny neck. You have to explore those comments fully.
And we also need to ask about other postoperative problems.
Definitely. Ask specifically about previous postoperative nausea and vomiting, or PONV, any unexpected ICU admissions, or any breathing trouble after the tube came out, like stridor. If there's a history of an ICU stay, you need to get the full story of that admission.
Oh, let's talk about drug history. This is a massive area for exams because the decisions we made on the morning of surgery are critical.
Meticulous is the word here. You have to cover everything. Prescriptions, Over-the-counter meds, supplements, and crucially, all herbal medications. You need the exact dose, frequency, and any recent changes.
Let's start with antihypertensives. This is where the rules can get nuanced and are very frequently tested.
Right. So for the most part, cardiovascular medications should be continued throughout the perioperative period. That includes beta blockers, calcium channel antagonists, and nitrates.
And the rationale is key. You can't just state the rule.
You must explain it. Abruptly stopping a beta blocker can cause a serious rebound, tachycardia, and hypertension. It's dangerous.
But then we come to the famous Viva trap. ACE inhibitors and ARBs. Let's break this down.
It's critical. The general recommendation is to discontinue ACE inhibitors and ARBs on the morning of surgery. And you need to know the mechanism.
It's all about angiotensin II.
It is. These drugs block the RAAS system. So when you induce anesthesia and the patient vasodilates, they've lost their primary compensatory mechanism to vasoconstrict.
Which leads to refractory hypotension.
Exactly. A profound drop in blood pressure that doesn't respond to your usual pressors like ephedrine. You might need to reach for vasopressin. And for diuretics, the rule is simple. Omit the morning dose and check their electrolytes, especially potassium.
Now for anticoagulants and antiplatelets, this is always a balancing act between bleeding and clotting risk.
It's a multidisciplinary decision. You have to talk to the surgeon, maybe a hematologist. For aspirin, continuing it perioperatively does increase bleeding risk. So we now advise selective continuation only for very high-risk patients.
Such as?
Someone having vascular surgery, a patient with high-risk unstable coronary disease, or someone who's had a stroke within the last 6 months.
And what about something stronger, like clopidogrel?
Clopidogrel and the other P2Y12 inhibitors generally need to be stopped for a full week before high-risk surgery. This allows for platelet turnover.
The major exception being a recent coronary stent.
The one major exception. The risk of stent thrombosis is just too high. For the DOACs and warfarin, they also have to be stopped according to specific protocols. If you're bridging warfarin, you must involve a hematologist.
And finally, what are the specific drugs we must always ask about by name?
Always make a special inquiry about steroids. You need to know the dose and duration because of the risk of adrenal suppression. And always confirm all herbal medications because so many of them can interact with coagulation or anesthetic drugs.
Moving on to allergy history. What do we need to cover?
You need to be thorough. Document all drug allergies and, importantly, the type of reaction. Was it a mild rash or was it true anaphylaxis?
And latex.
You still have to ask about latex allergy. It's less common now, but an allergy requires a completely different operating room setup. Also ask about food allergies, since some, like bananas or avocados, can have cross-reactivity with latex.
What if they have a history of anaphylaxis?
If they do, you try to grade it. Was it moderate, life-threatening, or did it lead to cardiac arrest? This helps you prepare.
Okay, family history. This is where we screen for those rare but potentially catastrophic genetic emergencies, a classic Viva station.
Indeed. You must specifically, by name, ask about malignant hyperthermia, or MH.
Give us the exam definition.
It's a rare, life-threatening, autosomal dominant hypermetabolic syndrome. It's triggered by volatile anesthetic agents and succinylcholine. You have to document any suggestive family history, rigidity, high fever, or an unexpected death during a previous anesthetic.
And what's the clinical paradox you have to mention?
The paradox is that nearly half of all patients who have an MH crisis have had at least one previous, completely uneventful anesthetic with the same triggering agents. So a clean past history doesn't protect you.
And the other big one to ask about?
Atypical pseudocholinesterase. This leads to that prolonged muscle paralysis after succinylcholine or suxamethonium apnoea. You have to explore that fully. And then just ask about any other anesthetic problems in the family or even subtle clues like unexplained fevers or a history of exercise-induced rhabdomyolysis.
Let's cover social history. This can influence everything from lung function to drug tolerance. Let's start with smoking.
You need to quantify it. How many per day and for how long to get the pack years. A 20-pack year history is a marker of significant damage. And most importantly, when did they stop? The anesthetic implications of smoking are a very common exam question.
And for alcohol and substance abuse, we should be using validated tools, right?
Yes. For alcohol, you should screen for a use disorder with something like the CAGE questionnaire or AUDITCC. These patients have higher rates of postoperative complications and, importantly, they can have altered tolerance to our drugs.
What about general substance abuse?
You need a detailed, non-judgmental history. The drug, the route, their recovery status. The key point for us is that patients on opioid substitution therapy, like methadone, have normal pain responses. They will need more analgesia postoperatively, not less, because their baseline opioid receptors are already occupied.
That is a very high-yield management point.
It is. And finally, just check for any occupational exposure to things that might have damaged their lungs, like asbestos or silica dust.
Now, for what might be the single most important physiological assessment we do? Functional capacity.
It's the bridge between their past medical history and their current physiological reality. We quantify it using the metabolic equivalent of TASC, or MET.
And what is one MET?
One MET is the energy you consume at rest. It's about 3.5 milliliters of oxygen per kilogram per minute. The benchmark we're always looking for is whether a patient can achieve 4 MET or more.
Which is roughly equivalent to what activity?
Climbing a flight of stairs or walking briskly on level ground without having to stop.
Okay, now let's talk about the big vivia trippy that comes with assessing METs.
The trap is relying only on what the patient tells you. The subjective assessment is notoriously unreliable.
Why is that?
There was a big study that showed that an anesthesiologist's subjective assessment was only 19% sensitive at identifying patients who couldn't actually reach 4 METs on formal exercise testing. Patients are just poor historians of their own fitness.
So how do we get a more accurate picture? What are we looking for in their dyspnea grading?
We're looking for objective signs of limitation. If a patient develops severe shortness of breath or chest pain or just profound fatigue while doing a simple low-level task, that tells you everything. It signals a severe lack of cardiopulmonary reserve, and it immediately puts them in a higher risk category no matter what they tell you they could do.
Okay, so the history sets the stage. Now, the physical exam. This is where we confirm our suspicions and, crucially, identify anatomical risks.
Exactly. We have to be systematic. Start with the basics: height, weight, and BMI. These aren't just numbers. You need them for drug calculations, for equipment sizing, and to assess obesity-related risks like obstructive sleep apnea.
And, of course, a full set of vital signs.
Must be measured accurately. A blood pressure of 180 systolic isn't just a number to write down. It's a major risk factor for perioperative stroke and death. It needs to be optimized before any elective procedure.
What general signs should immediately make our ears prick up?
You're looking for pallor, suggesting anemia, cyanosis for poor oxygenation, clubbing for chronic hypoxia, and edema, which points to heart or kidney failure. And you have to assess their nutritional status. Malnutrition is incredibly common in the elderly and has a huge impact on wound healing and immune function.
Now for the exam favorite, the section that defines their specialty, airway assessment.
This is mandatory before every single anesthetic. And you must stress this point. A previous easy airway does not guarantee an easy airway this time. Things can change.
Let's start with the classic clinical assessments, the Mallampati classification.
The Mallampati looks at the size of the tongue relative to the oral cavity. Class 3, or free, where you can't see the uvula or pillars, suggests a higher likelihood of difficult laryngoscopy.
And the technique is important.
Very. The patient sits up, opens their mouth as wide as possible, and sticks their tongue out without saying, ah, because phonating falsely lifts the soft palate and can give you a better-looking but inaccurate view.
What about the numbers? The quantitative measurements we need?
Mouth opening.
Yeah.
You want an incisor distance of at least 3 centimeters, or about 3 the patient's own finger breadths. We also assess the thyromental distance, which should ideally be more than 6 centimeters.
And neck mobility.
Crucial. You need to check for extension and flexion. A stiff neck from arthritis or a planned cervical fusion severely limits your ability to get the patient into the sniffing position and align the airway axis.
The area that can be easily overlooked is dentition.
It requires formal consideration every single time. Check for loose teeth, caps, crowns, dentures. Combination of loose teeth and limited mouth opening in an emergency can turn a simple intubation into a disaster.
So to round this out, what are the specific predictors of difficult mask ventilation and intubation that you should list in an exam answer?
For difficult laryngoscopy, it's a high Mallampati score and limited neck movement. But for difficult mask ventilation, you need to list the specific risk factors. There are mnemonics for this, but they include things like obesity, a beard, being edentulous, age over 55, and a history of snoring or sleep apnea.
And objective data can help here too.
Yes. If a patient with sleep apnea tells you they need a CPAP pressure of more than 10, that's a big warning sign. It tells you their airway collapses easily, and you're going to have a hard time keeping it open with a mask.
Okay, after the general and airway checks, we move to a focused systemic examination. Let's start with the cardiovascular system.
Auscultation is mandatory. You're listening for any new murmurs or extra heart sounds.
Yeah.
If they have a pacemaker or AICD, you need to note that and know if it needs to be interrogated.
And the peripheral circulation.
You have to meticulously check all the peripheral arterial pulses and listen for brutes over the carotids, the abdomen, the femorals. A brute is a sign of peripheral vascular disease, which is a very powerful predictor of coexisting coronary artery disease.
Respiratory system next.
Inspection is first. You're looking at chest symmetry, any use of accessory muscles. Then auscultation for wheezing, which indicates bronchospasm or crackles, suggesting fluid or consolidation.
And the central nervous system.
A brief neurological exam is vital to identify any pre-existing deficits. This is so important for medical legal reasons, especially if you're planning an neuraxial block or complex positioning for something like scoliosis surgery.
And for regional anesthesia specifically.
If you're planning regional, a careful spine examination of the lumbar area is non-negotiable. You're looking for any local infection, severe scoliosis, or evidence of previous spinal surgery that might make the procedure impossible or unsafe.
Okay, so we've gathered all this information from the history and exam. Now we have to consolidate it. This brings us to risk assessment and stratification.
And the primary tool for this, the one you must know inside out, is the ASA Physical Status Classification.
What are the key things to say about the ASCPS system in an exam?
You should mention its history. It started way back in 1941, with the latest update in 2019. Its function is to stratify risk based purely on the patient's physiological status, not the surgery. And its advantages are that it's simple, universally used, and a good general predictor of outcome.
But examiners love to test critical thinking. They will ask you about its limitations.
And you must be ready for that. The biggest limitation is that the ASA class alone is a blunt instrument. It doesn't account for the risk of the surgery itself.
Can you give an example?
Sure, an ASA3 patient having a minor endoscopy is at a vastly different risk than the same ASA3 patient having a major aortic reconstruction. The ASA class doesn't capture that surgical risk at all.
So how does this overall risk assessment, including the ASA grade, actually influence our anesthetic plan?
It's critically important. It determines our resource allocation. It helps us identify who needs a higher level of postoperative care, like a guaranteed ICU or HDU bed, or maybe even planned postoperative ventilation.
And you have to remember the two biggest risk factors.
You must state them. Emergency surgery and an ASA class of 3 or greater are the two key independent preoperative risk factors for adverse outcomes.
And when we, as anesthesiologists, designate a patient as high risk, that designation carries real clinical weight.
It does. Studies have shown that when that high-risk designation is documented and acted upon, it's associated with lower postoperative complication rates. It's tangible proof of the value of the whole pay-as-tape process.
Right. This leads us perfectly into investigations. This is where you have to show that you're practicing evidence-based medicine, not just ordering a standard battery of tests for everyone.
That concept of clinically directed testing is the key takeaway. You're not doing a shotgun approach. The purpose of any investigation is to answer a specific clinical question.
And what are those questions?
There are 3 main ones. 1, to determine the severity of a known disease. 2, to establish how much organ reserve the patient has left. And 3, to help with risk stratification and guide optimization.
So we must stress the importance of an individualized approach and avoiding unnecessary tests.
Absolutely. Arbitrarily routine testing is not justified. It's expensive, it can lead to false positives and unnecessary delays, and it rarely changes the plan for an otherwise healthy patient having minor surgery.
Let's give some concrete examples. How do we link our findings from the history and exam directly to the investigations we order?
Okay, let's start with what might be considered a routine baseline for a moderate to major elective case. That would typically be a complete blood count, renal function tests like urea and creatinine, maybe liver function tests, glucose, a basic urine analysis, an ECG, and a chest x-ray.
And for specific high-risk scenarios, what becomes mandatory then?
If you have a patient with known heart disease or someone you flagged as high risk, you should be considering a 2D echocardiogram or a formal stress test. The preoperative ECG is mandatory, and you must compare it to previous ones to look for any interval changes.
And for patients with CKD or those on diuretics?
For them, an immediate check of their serum electrolytes, especially potassium, is critical. And you look at their ECG at the same time for signs of hyper or hypokalemia, like peak T waves or a long QT interval.
Finally, pulmonary investigations.
Formal pulmonary function tests, or PFTs, are really only required if you're planning lung isolation for thoracic surgery, or in patients with very severe, poorly controlled COPD or asthma where you need a baseline to guide postoperative care.
The entire POCI process culminates here. Optimization and anesthetic planning. This is the so what section. How do we turn all our findings into an actionable plan?
It starts with a clear identification of problems. And this is more than just listing their comorbidities. It's about identifying the specific anesthetic risks: a difficult airway, poor cardiac reserve, dehydration, malnutrition, or complex drug interactions.
And what are the modern optimization strategies we should be citing in the exam?
You must mention the expanded role of the anesthesiologist in things like multimodal prehabilitation, basically getting the patient fitter before surgery, and formal smoking cessation programs.
And we have to reiterate the specific drug management points.
Yes, this is very high yield. Reiterate that you're continuing beta blockers, holding ACE inhibitors, and managing anticoagulants according to strict protocols. And of course, correcting any significant electrolyte imbalances.
So how does all of this funnel down into the final choice of anesthesia?
It's a holistic decision. It depends on their ASA status, the surgical site, the invasiveness. For example, if you identify a patient as being susceptible to malignant hyperthermia, the choice is made for you.
It has to be total intravenous anesthesia.
It must be Tyvia. You have to avoid all triggering agents. On the other hand, regional anesthesia is often preferred for things like C-sections or eye surgery to reduce systemic stress, but only if you've ruled out contraindications like a coagulopathy or sepsis.
And the plan doesn't stop when the surgery ends.
It absolutely does not. You must detail your plan for postoperative care and any potential ICU need. A high-risk elderly patient might need a critical care bed booked in advance. You don't want to be scrambling for one at the end of the case.
Okay, let's talk about the final crucial steps: documentation and communication. This is all about safety and compliance.
The foundation here is the pre-anesthetic checkup form, or PACSI form. Using a structured, standardized form, whether it's on paper or electronic, is essential.
Why is that structure so important?
It prevents vital information from getting lost. If you've identified a difficult airway or a critical allergy, that needs to be documented in a place where the next provider, the one in the OR, cannot possibly miss it.
And what about our communication responsibilities?
It's multifaceted. First, you have to communicate the risks to the patient and the surgeon. This is part of the shared decision-making process. Second, you have to clearly communicate your entire perioperative plan, the risks you've identified, the optimization you've done to the whole team.
And this ties back directly to informed consent.
It does. The documentation must show that the plan, the alternatives, and the risks were all presented and understood by the patient. And finally, you have to stress the importance of robust handoff communication.
When you're transferring care to the recovery room or the ICU.
Exactly. Using a standardized checklist for that handoff, covering the key history, allergies, how easy the intubation was, fluid totals, and any complications, is a critical safety step.
All right, let's get tactical. This segment is all about exam strategy. What are the most common exam questions and the Viva traps that students fall into?
Okay, the frequently asked long and short questions are always on the core concepts. You can expect things like goals of the pre-anesthetic checkup, the ASA classification, its importance and limitations, hazards of smoking relevant to the anesthetist, or a case-based question like preoperative evaluation of a patient for a C-section.
And the specific high-risk topics?
Malignant hyperthermia, susceptibility, and management is a big one. And of course, the comprehensive evaluation of the difficult airway.
Now let's drill down on the mistakes. What are the top 5 common student mistakes or Viva traps to avoid?
Okay, number 1, and it's a huge clinical error: failing to check the previous anesthetic records. Missing a documented difficult intubation is a major failure. Number 2.
Failing to ask about specific family history. You miss MH or atypical pseudocholinesterase. It's a simple question with massive implications.
Number 3.
Mismanaging high-risk cardiovascular drugs. Abruptly stopping beta blockers or forgetting to hold an ACE inhibitor. These are basic errors that show a lack of understanding.
What's number 4?
Relying only on a subjective assessment of functional capacity. Just asking, "Can you climb stairs?" isn't enough. You have to show you can think critically about what their answer really means.
And the 5th trap.
Failing to do a systematic airway exam, just looking at the Mallampati score, moving on. You have to formally assess dentition, neck mobility, and mouth opening every single time.
So if an examiner hits you with a high-risk scenario, what are the safe, examiner-approved answers? Let's start with malignant hyperthermia.
For MH susceptibility, your answer must be clinical and decisive. We avoid all triggering agents. That means no volatile agents and no succinylcholine. The mandatory technique is total intravenous anesthesia, or TIVA.
And you should probably know the caveat about prophylactic dantrolene. Yes, you should add, prophylactic dantrolene is generally not required, as it can cause muscle weakness and nausea unless a specific institutional protocol for a very high-risk patient requires it.
And for a patient who is a chronic opiate user, how do you manage that?
The safe answer focuses on empathy and proactive management. You reassure the patient their pain will be managed properly. You see that you would involve the acute pain service early, and you anticipate that they will have increased analgesic requirements and you will meet them.
Excellent. Now, in a theory exam, presentation matters. How can we use diagrams and structure to maximize our score?
Structure is everything for that 20-mark answer. You should plan to include visual elements. For airway assessment, you should describe and even draw a simple diagram of the Mallampati classification. You must also list the key quantitative measurements, like mouth opening greater than 3 centimeters. It shows you know the practical details.
And for the ASA classification?
You must include the ASA classification table, a simple table with classes I through V and the E modifier for emergencies, and mentioning the 2019 update shows your current.
So finally, give us the blueprint, the logical structure for that 20-mark answer on PAC.
Okay, you must use clear, bold headings. Start strong with definition, goals, and importance. Then, general principles. The main body, the core of your answer, is the detailed history and detailed examination, each with its own systematic subheadings.
Then risk and planning.
Exactly. After the exam, you move to risk stratification with ASA. Then a brief section on investigations, stressing the selective approach. Then optimization and planning. Finish with documentation and communication. That logical flow is crucial for a long answer.
Perfect. So what does this all mean? Let's distill this down to the highest yield takeaways for exam success.
Okay, the bullet point recap. PAC is all about systematic risk assessment and optimization. The ASA grade is crucial, but you must state its limitations. A history of a previous difficult airway is the single best predictor.
And the subjective METs assessment is unreliable.
Unreliable. Be meticulous with the drug history. Know what to hold, like ACE inhibitors, and what to continue, like beta blockers. A family history of MH means you're planning for TIVA. And always justify your investigations. No routine testing.
Let's do a rapid-fire top 10, the facts that must be committed to memory. Go.
1. ASA class greater than or equal to 3 and emergency surgery are the top 2 risk factors. 2. Hold ACE inhibitors and ARBs on the morning of surgery. 3. History of difficult intubation is the most predictive factor.
4.
A good Mallampati score does not rule out a difficult intubation. 5. You must document a reassessment within 48 hours of surgery. 6. Patients on opioid substitution therapy will need more analgesia.
7.
Clopidogrel must be stopped for a week before high-risk surgery. 8. A previous clean anesthetic does not rule out MH. 9. The anesthesiologist's role now includes prehabilitation.
And 10.
10. The presence of peripheral brutes is a strong indicator of coexisting coronary artery disease.
Fantastic. That is the high-yield summary you need. Now let's bring it all together. Give us that model conclusion paragraph for a 20-mark answer.
The pre-anesthetic assessment is unequivocally the cornerstone of safe perioperative care, defining the anesthesiologist's role as the perioperative medical specialist. By systematically conducting a thorough history and physical examination, focusing particularly on quantitative functional reserve and key anatomical and physiological risk factors like ASA status and difficult airway predictors, we identify, stratify, and initiate optimization of patient conditions. This integrated multidisciplinary approach ensures enhanced patient outcomes and significantly reduces the incidence of preventable perioperative morbidity and mortality.
Perfect. That's the authoritative statement you need to finish your answer. Now, for one final provocative thought for you to consider as you study. Given that the ASA classification system is now over 80 years old and we know its limitations, how much longer will our specialty rely on this relatively simple score before things like pharmacogenomic profiling become the routine standard for truly tailored, individualized anesthetic planning? That's something to think about as you master the foundations of PAC.